There we go. Okay, so you all should be strapped in now and enjoying the ride through the endocrine system. As I said in my announcement before, this system can be as challenging as the autonomic nervous system, but for different reasons. It's challenging because it's very clinically relevant, very clinically relevant. Arguably, there are at least 2 of you statistically in this class that have had some sort of hormonal problem. If you're female, I would put money on a thyroid problem. But also, if you're female, I could put money on reproductive issues if you were trying to get pregnant. And strangely, thyroid issues are directly linked to reproductive issues. So I'll talk about that as we go through. And we do start with the endocrine system in physiology, and we hit it pretty hard. There's a lot of physiology that I am going to be teaching you today, specifically about negative feedback mechanisms. And this is also in the anatomy textbook. So it's not an egregious outreach or far-reaching teaching moment for me to have you understand these concepts. So it doesn't look like I'm going to cover a lot, but there is actually a lot. You're going to find out that the way hormones are released from endocrine glands comes down to 3 different mechanisms, and you basically need to know which of the 3 a particular endocrine gland is using in order to release its hormone. So there is quite a bit to cover. A hormone basically is a chemical signal. It is a chemical signal very much like a neurotransmitter. Neurotransmitters are released from the end of a neuron, the terminal bouton, and that neurotransmitter goes into the synaptic cleft. It diffuses a short distance before it reaches receptors on the target cells. And you learned about that basically in lecture unit 3. And you also learned about it in lecture unit 1 when you learned about how skeletal muscle contracts. Hormones are very similar to neurotransmitters in that they are a chemical signal, but here's how they're different. They are released into the bloodstream. They diffuse throughout the entire body, and that means they could come into contact with a lot of different tissues. However, only certain cells or tissues will actually respond to it. And those that respond to a hormone we call target cells. And what makes a target cell a target cell? They have to have a receptor. They have to have a receptor for that hormone. It's a lot like, I ask students, how many of you have satellite TV versus cable? And some students raise their hand and say, I have satellite. Well, those images, those signals are coming through space. Why don't the rest of us, why aren't we able to get those images and those signals? And the answer is, well, you don't have a receiver, right? So instead of receiver, put the word receptor. They have to have a receptor. And it's not just enough that they have a receptor, it has to be a functional receptor. These receptors are proteins. So if the gene is mutated, then the receptor protein might not work right. And then the tissue will behave as if the signal never was released in the first place. This is an issue clinically over and over and over again. So it's not that I'm trying to belabor a point and like be the minutia of it. No, it's clinically important. A hormone additionally can have many different target cells, and each target cell will behave differently. What makes them behave a certain way? It depends on their gene expression. It depends on their physiology. For example, epinephrine is not just a neurotransmitter, it is also a hormone. Okay, epinephrine, when it targets the heart, tells the heart to beat with greater contraction and rate. Yet epinephrine can also target muscle in your gut. The last thing you want to happen is, if you're running for your life, that you have to go big potty. So epinephrine clearly does not tell the smooth muscle in your gut to contract more. That's not what happens. It tells it to do that less. So each target cell will respond according to its gene expression, according to how it should behave. A heart will behave like a heart. The lungs will behave like the lungs. The gut will behave like the gut. And we're going to find out that a lot of hormones have far-reaching abilities. They target a lot of different target cells. So that's what I mean by pre-programmed. The effects of a target cell are pre-programmed. It's their gene expression. The three major ways that cells or target cells, I shouldn't say, sorry, strike that. The three major ways that endocrine glands release their hormones are through these three mechanisms. Humoral. Humoral means in the blood. So something in the blood triggers the hormone to be released. For example, insulin. Insulin uses a humoral mechanism. If you eat and your blood sugar goes up, then that is the stimulus to tell the pancreas to release insulin. So that's what we mean by humoral. I'm trying to adjust my laptop here so that you don't just see my eyes. There, that should be better. So that's what we mean by humoral. Something in the blood triggers the endocrine gland to release the hormone. Another example would be a hormone that I'm going to tell you about, parathyroid hormone. Parathyroid hormone is released by the parathyroid gland. And what stimulates parathyroid hormone to be released is if your blood calcium levels drop too low. So that will trigger the parathyroid gland to release its hormone. The other way that endocrine glands can release their hormone is through a neural mechanism. You actually already learned about this in Unit 3. You learned that you can have epinephrine released from the adrenal medulla. The cells in the adrenal medulla, I told you last unit, are modified postganglionic cells. So you would think of that as a neural mechanism. They are modified neurons, so that when they release the epinephrine into the blood, it actually came from nervous tissue. And the reason why we don't call it a neurotransmitter anymore is because the signal is released into the blood, and so technically now it's a hormone. The last and major way I will focus most of the class on is the hormonal pathway. And this means that you have an upstream gland releasing a hormone that in turn tells a downstream gland to release its hormone, which in turn tells a third downstream gland to release its hormone. So it's a chain of commands. One hormone from one gland telling another gland to release its hormone, telling a third gland to release its hormone. So right about now, I tell a very off-colored joke, and just because, why not? Well, do you know how we make a hormone? You don't pay her. Wah, wah, wah. It's my little joke. But seriously, when we're talking about control of hormones, hormones are controlled in two different ways. They are controlled either through positive feedback or negative feedback mechanisms. the safest way to control a hormone, and by controlling it, I mean, you wouldn't want too much of it released, right? You want just enough of it released to make the changes that the body needs to make. You don't want to keep bombarding the target gland, because if you bombard it with too much, you're going to have diseased states. So one way that we control the way that an endocrine gland regulates how much hormone it releases is through positive feedback. Most hormones are not regulated by positive feedback, and here's why. In physiology, you will learn that positive feedback mechanisms, your body should only use them if and when the body needs to make profound, immediate, drastic changes. For example, let me start with something that you can recognize. In Unit 2, you learned about blood. And you learned about blood cells, in particular formed elements. One of the formed elements you learned about was platelets. Platelets are important for clotting. I'm sure you appreciate that most of the time your blood should be in a liquid state, right? The heart has to push your liquid blood around. But if you slice your finger with a knife, there should be immediate changes that turn your liquid blood into this gelatinous clot. And that stops your bleeding, right? Clotting. And when you learn about the clotting process in physiology, you will realize that activated clots lead to even more activated platelets, lead to more clotting formation. So more leading to more, leading to more. More leading to more, leading to more. If that is somehow not stopped, the ultimate way that a positive feedback will be stopped is by death. So I'm sorry, I'm distracted. I have a whole household of people right now, and they're leaving, and I can hear them. A whole bunch, my nieces and nephews. Okay, they're gone now. It was distracting. Anyway, positive feedback, more leading to more, leading to more. All positive feedback mechanisms must be ended with a negative. They need to somehow be told to reset, to go back to the start. If they are not told how to reset, then the ultimate feedback will be death. That's how it's going to end. Now, there are other examples of positive feedback where we get more leading to more, leading to more. The example shown here is the breastfeeding mother. So basically what happens is it frequently starts with mom hearing her baby cry. And she knows that baby is crying because it's been 3 hours since the baby has fed. So the mom puts the baby to the breast and the baby starts to suckle. That actual physical contact and stimulus through the breast tissue, afferent fibers go up to the hypothalamus. And the hypothalamus makes a hormone called oxytocin. And this hormone is stored in the posterior pituitary. And I'll show you pictures of these structures again in just a few moments. So the hypothalamus gets all of these afferent signals saying the baby is at the breast. The oxytocin is released into the bloodstream, and it goes everywhere in the body. And one of its target cells are the glandular cells in the breast tissue. And oxytocin causes the glandular cells to basically secrete the milk. And as the baby continues to suckle, More suckling leads to more oxytocin, which leads to more milk ejection, which leads to the baby still suckling because now it's got all this milk squirting into its throat, and it keeps sucking. What they don't tell you when you birth your child and you think, oh, it's wonderful, I'm going to breastfeed, it'll be a wonderful experience. What they don't tell you, my young ladies out there, is that oxytocin also targets your uterus. Oxytocin is also responsible for the contractions you experience during labor. What they don't tell you is when you are breastfeeding your baby, in the first few weeks or so, that oxytocin going through your blood will still target your uterus. It is not uncommon while you're breastfeeding your baby to have severe uterine contractions, as if you're back in the hospital having labor pains again. And guess what? They do not send you home with an epidural in that case. You will have to sit there and take that pain and refrain from throwing your baby across the room. There are laws that say you shouldn't do that. So more leading to more. This even happens in labor. This is how we get labor to, quote, progress. What happens is when the woman is terminally pregnant with that full-term parasite inside of her, the parasite should turn head down. And because it's so big, it wants more room. And that parasite starts to stretch and move around a lot. And when it starts to move around, because it's got tight quarters now, it's gotten big, it's full term, it starts to stretch. And when that happens, the mother's uterus, being smooth muscle when it's stretched, it responds with a greater contraction. So the mom's uterus starts to contract and it pushes on the baby, and the baby's head hits the cervix of the mom. The cervix is hardwired to the hypothalamus. And as the cervix is stimulated, the hypothalamus releases oxytocin. Oxytocin causes uterine contractions. So the uterus contracts again, pushes the baby's head down on the cervix again. Cervix stimulates the hypothalamus. Hypothalamus releases more oxytocin. More oxytocin, more uterine contraction. More cervical stimulation, more oxytocin. More leading to more, leading to more, until the contractions come in close proximity and last longer and longer and longer. What will be the negative feedback mechanism? What will stop that system? Obviously, when the baby is born. When the baby is actually birthed, then there is no more stimulus on that cervix, and the amount of oxytocin should now go back down to the beginning state. Negative feedback mechanisms basically say once the hormone is released and the cell behaves the way it should behave, it's going to send a signal back to the endocrine gland and say, look, I obeyed your command. And then the endocrine gland, if it could talk, would say, oh, good job. Thank you for obeying the command. Now I will stop barking at you. I won't keep signaling. You did what I needed you to do. You gave me feedback. I don't need to keep doing this. And that's going to be our main focus, negative feedback mechanisms today. Most hormones follow negative feedback mechanisms. And I'm going to expand on this process in great detail as we keep going through this lecture. You just finished your exam on the nervous system, and you learned about how neurons fire, and you learned about action potentials, etc. If we compare and contrast the nervous system, both of them use chemical signals. They both do. We just call them different terms. So neurotransmitters are the chemical signals that are released by neurons, and hormones are the chemical signals released by endocrine glands. I guess the next thing is, what makes them, where are they released? So for neurotransmitters, they are released into the synaptic cleft. They diffuse a short distance and they target an immediate cell on the other side of that neuron. Right, we say neurons synapse on their effectors. But for endocrine glands, they release their chemical signal into the bloodstream, and that means it goes throughout the body. In the nervous system, the neurotransmitters most of the time tell the next neuron whether or not it should have an action potential or not, or tells skeletal muscle whether or not it should have an action potential and lead to muscle contraction. Hormones distributed through the body, distributed through the blood to the entire body, each effector will have its own outcome. The heart will respond like the heart, is what I said earlier. The nervous system, very quick. The neurotransmitters don't last very long. They lead to action potentials. They are very short-lived. So neurons stop firing when their stimulus stops. Hormones are not that way. Endocrine glands can keep releasing the hormone if they're not getting the feedback, if they're not getting the signal that other target cells are behaving like they should. Hormones can last for a long time. Some hormones can last for weeks, months, long time. Cortisol would be a good example of that. The endocrine system is also slower. It's slower to engage. It could take up to 45 minutes for a hormone to change the physiology of a target cell. That's the fastest acting hormone that we know of, 45 minutes. And it takes them a while to be released. Neurotransmitters can be released very, very quickly in milliseconds, but getting a gland to release a hormone can be more on the seconds. And then how long it can last can be days, even months. The hormone itself can continue to change the physiology of the target cell even after the gland has stopped releasing the hormone. So again, some hormones last a long time in your body, and I will address that. A good question right now is, what is the difference between an endocrine gland versus exocrine? And you are going to learn about exocrine glands and endocrine glands in Lab Unit 4. An exocrine gland is a gland that releases secretions into a duct, D-U-C-T. And this duct is lined by epithelium. It's a tube. Your pancreas, for example, is an exocrine gland. It releases digestive enzymes through the pancreatic duct into your small intestine. It is also an endocrine gland. An endocrine gland is something that releases a chemical signal into the bloodstream. And yes, some glands can be both. In Lab Unit 4 and also in this lecture unit, you're going to learn about the integument system. The sweat glands in your skin, for example, are exocrine. They release the sweat into the duct, the tubular lumen. It's coiled usually, and then those secretions find their way to the surface of the body. The surface of the body can be truly the surface of your skin in this example, or the surface of your body can be thought of as the lumen of your digestive tract. Eventually, anything in your digestive tract will eventually reach the surface of your body, especially when you go to the bathroom. So it's going to reach the surface of your body in some way. Another example of an endocrine and exocrine gland that you're going to see would be the gonads. Men have testes, women have ovaries. Testes are both exocrine and endocrine. They are endocrine because the testes release testosterone into the bloodstream. They are also exocrine because the testes eventually, with their spermatogenesis, the sperm are going to be ejected through a duct and eventually will reach the surface of that man's body, or at least his bed sheets. Either way, it's coming out to the surface of the body. Well, what about ladies? Well, your ovaries are both exocrine and endocrine. They are going to release estrogen and progesterone into the bloodstream, and I will talk about that. But yes, ladies, they are also releasing something that will reach the surface of your body, and that is an oocyte that eventually finds its way out of you, especially when you shed your uterine lining. That oocyte comes out along with a layer of your uterus. That's super fun, isn't it? When you go to the bathroom and half your uterus dumps into the toilet. So now, let me review again how hormones are released, the three mechanisms. The one that we're going to focus on the most, and I'm going to wait to talk about that in great detail, is the hormonal mechanism. This means one endocrine gland releases a hormone that will target another endocrine gland that will release a hormone as well. So here is an example of the hypothalamus, an endocrine gland. It's releasing a hormone onto cells that are found in the anterior pituitary. And that hormone tells the cells of the anterior pituitary to release their hormone. And then those hormones are released from the anterior pituitary and they go to a third endocrine gland, for example, the thyroid gland. And then it releases its hormone. We frequently think of this as the that is not pretty. There we go. The HPX pathway. Hormonal pathways start with the hypothalamus, continue with the anterior pituitary, and then there's some third downstream gland that will be targeted. And the X means fill in a particular gland that you want to discuss. If I say HPT, it represents hypothalamic pituitary thyroid gland. If I say HPG, it represents hypothalamus pituitary gonad. If I say HPA, it stands for hypothalamus pituitary adrenal gland. And in physiology, we call this an axis. An axis is a chain of command, right? The first gland signals the second gland, signals the third gland. It's a chain of commands. I'm going to focus a lot of this lecture on that chain of command. The other ways that we have release of hormones is humoral. That means something in the blood tells the endocrine gland, hey, things are not right and you need to adjust this. Great examples are insulin. If you eat, your blood glucose levels go up. That tells your pancreas, hey, sugar levels are getting too high. We should release the insulin from the pancreas, and that tells insulin-dependent cells of your body to bring the sugar into the cells. As the cells bring the sugar from the blood into the cytoplasm, your blood glucose levels fall back down to normal. If your blood glucose levels get too low, that is also a signal. It will also signal the pancreas. And in this case, the pancreas will release a different hormone called glucagon. And I'll talk about this more later on in the lecture. Glucagon, just to give you a little teaser, is a hormone that basically tells you what the problem is. Glucagon, glucose is gone. And glucagon tells the liver to release stored glucose into the bloodstream because glucose is the primary fuel for your brain. It cannot go without. The third stimulus that you actually have already learned about is a neuronal stimulus. And you can see in this picture that we have neurons that are synapsing with the adrenal medulla. We know from Unit 3 that the adrenal medulla is actually modified postganglionic sympathetic cells, and they release endocrine into the bloodstream. And this is what allows our sympathetic division to respond in what we call en masse, all together. Now, before I move on, I need you to learn some terms. So I'm going to create a slide here. And here are the new terms that I need you to know. And these are really good, important terms to know. Set point. Yes, of course. Set point. Everything in set point and variable. Let's start with variable. That's better. A variable is anything in your body I can measure. Anything. It can be heart rate. It can be blood pressure. It could be your hematocrit. It could be your white blood cell count. It could be your urine flow. Anything about your body I can measure. That's a variable. When you go to the doctor and they do blood and urine analysis labs, you get pages of data, don't you? Pages of data. Those are all pages of reports of what your variables are like. Your red blood cell count, your lymphocyte count, your neutrophil count. They give you a report on every variable that's in your blood and your urine. If you notice on your urine and blood labs, they flag, don't they flag anything that's out of range, don't they? Anything that's out of normal range, they flag. And then your doctor talks to you about that. It might be your cholesterol. It might be that your white blood cells are too low in count. It might be that your red blood cells are too low in count. But your doctor reports back to you, hey, this was not okay. So set point is a fancier way of saying normal range. In physiology, we don't say normal range, we say set point. But it's basically, they are synonyms. Set point makes a student think that there is one value that is okay. It really is a set range. It's an acceptable range. So we look at all of your variables and we assess if they are in an acceptable range, set point. Deviation is a word, a single word that says your variable is no longer in the acceptable range. So that took me a while to say. I can simply say, hey, your red blood cell count has deviated. Deviation can mean that you have too much or too little of something, but you are out of an acceptable range. Most of the time, when your variables in your body deviate from set point, your body will try and correct for that. Your body is exquisitely able to help you get your variables back to where they should be. Very, very good at that. So that's called correction. Correction, also known as compensation. Sometimes your body is outmatched. Sometimes your variable has deviated from set point and your body is trying its hardest to correct and get your variable back towards set point, but it's outmatched. For example, right around spring break, I started to get a really bad sore throat. Those of you who have been on Zoom with me, and maybe you've heard the recent videos, if you listen to when I did the cat vein lecture versus the cat artery or the model vessel lecture, you can hear it in my voice how sick I was. For 2.5 weeks, I had this very, very sore throat, and I kept thinking, my body's gonna fight it off. I'm gonna fight it off, I'm fine. And it got to the point where it wasn't fine. I'd have good days where my white blood cells probably were fighting back the infection. And then I'd have bad days all over again, where clearly the infection was outmatching me. If the person's body cannot correct or compensate completely, that's where the diseased state sets in. And that's where medical intervention comes in. And many of you want to become nurses or PAs, and your job is going to be you recognize the disease state your patient's body is in, you figure out which variable has deviated, and then you try and prescribe or administer the correct assistance to get that variable back to where it should be. That's basically what medicine is. It's all about helping your patients with their variables get back toward set point. So go ahead. Was someone asking a question? No? Remember, you can unmute yourself if you want to. Okay, so we're going to use these words. I'm going to be using these words quite a bit as I go through different hormones. And I'll be explaining to you what is the variable and where should it be. That's the set point. What endocrine gland will respond if that variable deviates. And then the hormone should be the correction, the compensation. Once the variable goes back to where it should be, then there should be some sort of mechanism to tell the endocrine gland, hey, we're good now. You don't need to keep releasing the hormone. Hormones are precious resources. If the problem has been solved, the endocrine gland shouldn't keep releasing it. Enough is enough. You've gotten back to where you should be. Are there any questions about these terms? You're all okay? I'm turning you into little physiologists. Okay. Okay. So let's start with the hypothalamus, because that's going to be a huge part of our discussion today. I'll remind you that the hypothalamus is found just below the thalamus, hence the prefix hypo, which means below. We learned in lab unit 3 what the hypothalamus does. It's probably better to ask, what doesn't it do? It regulates your feeding behavior. It regulates your anger response. It is part of your sympathy. There are many sympathetic centers in your brain. The hypothalamus is one of those. But it's also an endocrine gland. And I want you to see right here that the hypothalamus can send a signal through sympathetic nerves basically preganglionic sympathetic nerves, and directly synapse with the adrenal medulla to tell it to release epinephrine. That would be a neural mechanism. So neural is in blue. There's also another example of a neural mechanism that I'm going to show you in green. There we go, in green. And that is the hypothalamic neurons extend from the hypothalamus, and I'll show you another picture of this, and they synapse, not on the adrenal medulla in this example, but they synapse, I shouldn't even say that, they extend into the posterior pituitary. A lot of students think the posterior pituitary is a separate gland. No, posterior pituitary is an extension of the hypothalamus. It's a lot like saying your leg is an extension from your torso. So those axons, their cell bodies are in the hypothalamus, but the terminal boutons extend into the posterior pituitary. There are two hormones that the hypothalamus makes and stores in the terminal boutons found in the posterior pituitary. That's oxytocin, which I told you about earlier about the breastfeeding mom and labor contractions, but also a hormone called ADH, antidiuretic hormone. I will be talking about antidiuretic hormone in more detail when you learn about your kidneys, your renal system. In red, will be the primary focus of today's class, the hormonal pathway, where the hypothalamus will release hormones into the bloodstream, which targets the anterior pituitary, which is a totally separate endocrine gland. And then the anterior pituitary releases one of these 7 hormones. So the anterior pituitary produces and releases 7 hormones. And I'm going to go through each one individually. Those hormones in turn will target other organs in the body. Many of these are going to be endocrine glands, like mammary tissue, gonads. And this is what we say creates your HPX pathway or axis. All right, so let me show you an up-close picture of the anatomy between the hypothalamus and the pituitary. So back here is the posterior pituitary. Up here is the anterior pituitary. Kind of cool, but these 2 regions of your brain had different embryonic origins. The posterior pituitary is really an extension of the hypothalamus. Early anatomists thought it was a totally different structure. It took them a while to figure out that the posterior pituitary is really still the hypothalamus. But by the time they figured that out, it was too late to change the vocabulary in the day. So posterior pituitary is also called neurohypophysis, which means it's an extension of the hypothalamus. It is still considered to be part of the brain, neural derived. The posterior pituitary, like I said, there are cell bodies in the hypothalamus, and their axons terminate into the posterior pituitary. And the posterior pituitary is where the terminal boutons of those neurons are found. The hormone is made here, so hormone synthesis. It travels through the axon, through cytoplasmic mechanisms, transporters, and then it's stored in the terminal boutons until that hormone needs to be released. And the two hormones that are released from this area are ADH and oxytocin. And I like to sing the Banana Boat song to remember this. It's a little corny. You know the Banana Boat song, right? Day-o, day-o. There's a reason why I'm not a singer. So instead of day-o, I want you to think nao, N-A-O, N-A-O, nao, nao. ADH will make you swell. Oxytocin, you scream like hell. That's how I remember it. So ADH, you will learn, makes your kidneys reabsorb more water. And if you reabsorb more water, that you're going to swell, right? You're going to get bloated. A lot of water retention. And oxytocin, why did I say you scream like hell? Well, you should have heard by now, it causes labor contractions. And you will, if they get bad enough, you're going to be screaming like hell. Right about now, men say, well, I'm so glad I don't need to worry about that. You might want to rethink that. Oxytocin is also released by men. Their hypothalamus releases oxytocin. You see, oxytocin has a more gentler side that we forget about. Your brain, your hypothalamus releases oxytocin when someone touches you. And when low amounts of oxytocin are released, it's almost like you're on ecstasy. It helps you feel more connected to the person who's reaching out and putting a gentle hand on your shoulder. I'm going to give some relationship advice here. Work this to your advantage. Anytime my honey starts to get mad at me for some, I don't know why reason, I reach out and I put my hand on his shoulder. And he calms down. And he can't help it. People can't help. The thing is, you shouldn't just randomly reach out to people, strangers, and touch them, right? You should probably ask, especially these days. But if you can touch someone, if they're angry, it usually calms them down. I use this also with my students that come to me distressed about something. I will just put my hand on their shoulder. That's very G-rated touch, and it helps calm them down. That's the oxytocin. Oxytocin is also required for uterine contractions beyond labor and delivery. This is where we get our big O, orgasms. And it's also the hormone required for men to have their orgasm. So I'll say it again. Nao, nao, ADH will make you swell. Oxytocin, you scream like hell. And that could be really good euphoric screaming too when you're having an orgasm. So either way you're screaming, one way or the other. It works. Now, what about the anterior pituitary? Well, still, we're going to see that there are neuronal cell bodies in the hypothalamus, but their terminal boutons are still in the hypothalamus. And they're going to release a hormone into this first capillary bed. And then those hormones travel to the anterior pituitary, and there are cells in the anterior pituitary. different clusters of cells. You might have somatotropes or gonadotropes. These are just different camps of cells. And trope means they're going to respond to the hormone from the hypothalamus, and in turn, they're going to release their hormone into this second capillary bed, which is all around the pituitary. You see, this is a double capillary bed. Where have you learned about this before? Did you say the hepatic portal system, which you've already had a test on? It's a double capillary bed. So this is called the hypothalamic hypophyseal portal system for hypothalamus and the hypophysis, which is another term for the pituitary. Somatotropes are going to be cells that will release a hormone that controls your body. That's what soma means, body. We're going to see that they release a hormone called growth hormone. So they're going to be in charge of how well you grow. Gonadotropes, for example, another camp of cells in the anterior pituitary, are going to release hormones that will target your gonads, like your testes or ovaries. Don't worry about these terms, but they, depending on the anatomy book you're using, it probably is in there, and I just want to explain these names. Somatotropes, gonadotropes, corticotropes, thyrotropes. There are different camps of cells in the anterior pituitary making these 7 hormones that I'm going to tell you about in just a moment. So let's do it again. Let's focus on the pituitary gland, the neural hypophysis. So the neural hypophysis, again, is an extension of the hypothalamus. It truly is still the hypothalamus. But again, early anatomists, they didn't have the microscopy available. They didn't realize it was technically still part of the hypothalamus, and then they had already named it, and it was too late to pull that back. The way that the pituitary hangs off of the neurohypophysis, hangs off the hypothalamus, is through the infundibular stalk, or infundibulum. And this posterior pituitary, like I said, is just an outgrowth of the hypothalamus. Now, the anterior pituitary actually does not come from your brain. It doesn't. The anterior pituitary actually originated back when you were an embryo. It originated from a pouch at the back of your throat. So down here in your throat region, this is where the anterior pituitary started to grow. It's kind of weird. Back when you looked like a fish and you had gill slits, that's where this came from. And as you continued to develop, the anterior pituitary grew and rose up superiorly towards the brain, and the hypothalamus grew this out portion of it, moving inferiorly. And now we have the anterior and posterior pituitary living in close proximity in your sella turcica. Remember that from Lab Unit 1, the sphenoid bone, the Turkish seat? That sella turcica is where these 2 very different endocrine glands finally came to coexist in your body. Move my screen here. I'm going to do it again. Here is our hypothalamus. Here are neuronal cell bodies. You can see their axons go through the infundibulum, and the terminal boutons, are found in this out pocket, this pouch that the hypothalamus grew. From these 2 different sets of neurons, we get ADH, which tells the kidneys you need to store more water. We'll get to that in our urinary section. or they're releasing oxytocin, which causes smooth muscle contraction, either in low amounts for orgasms or in higher amounts for uterine contractions for labor and delivery, or moderate amounts for breast milk expression, meaning to get the glands to release the milk. Weird kind of, well, weird or no, just the beauty of how your brain works. For my ladies out there that might entertain getting pregnant with a parasite and actually breastfeeding, your brain will become trained to the sounds of your baby, and not just your baby, any baby. So once your brain starts to quote unquote learn the system, it won't just take your baby sucking on your breast for your brain to start releasing oxytocin and telling your breast milk glands to release milk. Eventually, when your brain gets trained very well, it can be simply the crying of your baby that makes your milk, quote, let down. So hearing your baby cry, or even somebody else's baby cry, your hypothalamus will say, right then, I know that cue. That means hungry baby. I'm going to get ready. I'm going to get those breast glands ready. I'm going to release oxytocin. And that can be really annoying if you weren't planning on feeding a baby, especially if it's somebody else's baby that's crying. And then you start letting down your milk. And for those of you who have never breastfed, let me tell you, when you let down milk, it's not just like a little dribble of milk. It comes shooting out of your nipples, shooting out. It has projection. And you can let down so much just from a sound that triggers your brain. You wear these pads in your breastfeeding bra. It's a lot like maxi pads, but for your boobs. And if you let down your milk, you can actually soak through them, and then the milk is coming through your pads, through your shirt, and shooting out into the customer in front of you at the grocery store. It's really embarrassing when that happens. Yes, it has happened to me. My trigger was not just babies crying. I used to have a breastfeeding bra that had Velcro attachment, so it was easy for me to, basically pull on the bra and lower the panel, and then there's my boob. This man in front of me at the grocery store had a Velcro wallet. He opened his Velcro wallet. I'm unloading my grocery cart. I don't even know. Your boobs get the mind of their own. They're obeying the hypothalamus. Next thing I know, I'm spraying all the gum in the little checkout area and it was awful. I made a mess. So be careful. Make sure you wear a lot of boob pads, because it's crazy how much milk you can let down from this process. You've been warned. Well, what about the anterior pituitary? Well, now let's go through the anterior pituitary. We have hypothalamic hormone, neuronal cell bodies, and their axons stay in the hypothalamus. They release hormone, and that hormone travels into the first capillary bed. Hold on a moment. Okay, I'm back. So they dump the hormone into the first capillary bed, and then that hormone goes through the capillary bed a short distance to a second capillary bed. And the hormone will trigger those different camps of cells in the anterior pituitary for them to release their hormone. So the hypothalamus is considered the first in the chain. The anterior pituitary is considered to be second in the chain. And then the anterior pituitary hormones will target any of these third glands, any of these, to do what they should do next. So we have the HPT for thyroid, HPA for the adrenal gland that I'm going to talk about today. We can have the HPG right here for gonads. So those are the three axes I'm going to talk about. If there isn't a third endocrine gland, then we say that the hormone from the anterior pituitary was the terminal, like the end of the road. So the mammary glands are not endocrine glands. They're exocrine. They're going to release the milk. Muscle that responds to growth hormone or adipose tissue, those are not endocrine glands. They are basically going to be the targets of growth hormone. So the three examples that I'm going to tell you about will be the HPA, HPG, and HPT. So that's not the third one. There we go. Now, how can you remember these 7 anterior pituitary hormones? You can remember them with the acronym melons grow and produce through late fall. Melons grow and produce through late fall. Melons, the word melon stands for melanocyte stimulating hormone. This is what gives your skin color its pigment. The word growth stands for growth hormone, and it's the name of growth hormone tells you what's going to happen. Your muscles are going to get bigger. Your bone is going to increase the mitotic rate of the cartilage cells in your epiphyseal plates, and you're going to get taller. Adipose tissue will release fat because when you're growing requires a lot of fuel, and you're going to use a lot of the fatty acids that the adipocytes store as fuel for this growing process. A stands for adrenocorticotropic hormone, a horrendously long name. We abbreviate that as ACTH, and ACTH is going to target the adrenal cortex, not the adrenal medulla, the adrenal cortex. And we will again focus on that more when we get to our renal section, our kidneys. And then lastly, we have, we have prolactin for produce. You're going to produce basically the milk, and then the mammatropic cells in there are going to release prolactin to stimulate those milk glands to release milk. Or to, sorry, not release, but to make it. Oxytocin causes it to be released. T stands for TSH, thyroid stimulating hormone. Its name tells you what it's going to do. It's going to stimulate the thyroid and tell the thyroid to release its hormone called thyroid hormone. The last two, luteinizing hormone and follicular stimulating hormone, those two hormones are going to be important for gametogenesis, meaning making your oocytes or ovulating them, ladies, or in the case of men, making sperm. We will focus on those two hormones in more detail when we get to the reproductive system itself. Again, remember you can unmute yourself and ask a question if you want. This is a table from your book showing you the hormones made, stored, and released by the anterior pituitary. And the bottom set of this table, so these 7 are made, stored, and released by the anterior pituitary. The 2 hormones down here are merely stored in the posterior pituitary. They are made in the hypothalamus. Remember, the posterior pituitary is technically just an extension of the hypothalamus. And it tells you the target cells and what the target cells will do, which you need to know for both your lab exam number 4 and lecture exam number 4. Knowing the target cells and how they respond will definitely be on both exams. So let's go through some of these hormones and talk about the target cells and how they will respond. Let's start pretty easy. Growth hormone, released by the somatotropes of the anterior pituitary. Growth hormone tells you what it's going to do. It will stimulate bone tissue. Specifically, it will stimulate the chondrocytes that are found in the epiphyseal plates. They replicate and divide. It also leads to that calcified cartilage being turned into bone. We say this is osteogenesis. And we start to see the teenager getting really tall very quickly. Teenagers actually have a similar growth rate as toddlers. And it's very true for those of you who might remember the frustration of your parents. They might have purchased you new shoes or a pair of jeans, and within 2 months you outgrew them. And your parents might have gotten mad at you saying, "What? But there's nothing wrong with them. What do you mean you need a new pair of jeans?" Well, you grew out of them. You have a very accelerated growth rate during puberty. Once the epiphyseal plates close, you stop growing. So growth hormone helps this growth process. When you grow, it's not just about your bones. We forget that when you grow, you also need your skeletal muscle to increase in mass. You're getting bigger in more than one way, not just with bones, but with muscle. So your muscle needs more resources like amino acids. And growth hormone tells the skeletal muscle, hey, this body's going to grow. You need to start taking in more amino acids so you can make more actin and myosin. As we age, the amount of growth hormone we release decreases. And this is a lot of the reason why, as we age, we lose muscle mass. Even if we continue to work out, we still lose muscle mass. You're not going to be able to bulk up as much as you were able to when you were a teenager in high school. A lot of I wouldn't even say scientists, a lot of quack jobs out there oftentimes will say growth hormone is the holy grail of anti-aging. And there are a lot of places where they try and sell you growth hormone, or you should only take growth hormone if it's under a doctor's direction, please. Your growth hormone is typically released during the night when you're sleeping. So it's true you grow in your sleep, and your body's used to this. So anyone who's trying to sell you growth hormone, even if it's injectable, I would highly recommend you not muck around with that unless it is a physician that is overseeing this. Growing requires energy. Your adipocytes will release fatty acids that they've been storing so that your body can use those fatty acids as a fuel source. A lot of times before children start to grow, before adolescents start to grow, they pack on a lot of fat. They get a little chubby. That is not the time to start telling your teenager, hey, you're getting fat, you're not doing anything. They're packing on the fat because give them a couple more months, they're going to start sprouting and they need that fuel. And you don't certainly need to make them body conscientious in a negative way by giving them issues over their weight gain. They're going to stretch out. You should not say anything. The liver will do its job to make sure that the body has energy. The liver has a process called glucose, new, genesis, to make. So the liver can actually make new glucose. And it makes this glucose from alternative fuels, like fatty acids from the adipocytes. So it can use different macromolecules to make glucose to help with this process. If you have an excess amount of growth hormone released by the anterior pituitary before the epiphyseal plates closed, it can lead to gigantism. Here is the Alton giant. Oh, I have that on there. His father right here is 6 foot something tall. Look how much taller his son is over him. Andre the Giant, a famous wrestler, and he was one of the actors in an awesome movie called The Princess Bride. He also had gigantism. This has consequences. Usually those people with gigantism don't have a very long lifespan. They tend to die pretty early on, like 50s or so, because it's too much of a workload on their heart. I mean, think about where the Alton Giant's heart is, way up here, and how much work it has to send blood throughout that massive body. So they typically die of heart failure. Andre the Giant certainly died much too young. But what happens if you have too much growth hormone and your epiphyseal plates have already closed? Well, this is Professor Huska. He actually was one of our part-time instructors a while ago, and he ended up retiring from teaching because he started having an anterior pituitary tumor. Specifically, his somatotropes had become tumorous and they were producing excessive amounts of growth hormone. So this is when his tumor was just starting. Look at his brow, look at his mandible, look at his face in general. He just looks miserable. And when someone has their pituitary gland releasing too much growth hormone, even when they're no longer capable of growing, the bone gets bigger in thickness, not in height. Thickness, that's appositional growth. You learned about that in Unit 1. So if Dr. Huska turned his head, his brow would be very pronounced and his jaw would look really big to you. They went in and they removed the tumor, and finally his growth hormone levels went down and his bone remodeled. And you can see that his face went back to a much more chiseled look and his brow was not as pronounced. He was just miserable when that tumor was raging before he actually had his surgery. When someone is releasing growth hormone, like a growing teenager, in pretty high amounts, we say it is diabetogenic. That does not mean it turns you into a diabetic. What that word means is the growth hormone causes sugar levels in your plasma to remain somewhat elevated. It's antagonistic to insulin, so your glucose levels stay elevated. That should kind of make sense because you heard me just say that growth requires energy. It requires fuel. So when you are going through your growth, this hormone basically says, hey, We need more sugar. All of these cells are becoming more mitotically active in the bone, in skeletal muscle. They need fuel to get through this. So the glucose levels are maintained at a higher level during this time. So that's what we mean by diabetogenic. Okay. Focusing on Professor Huska, just kind of fun. Here is actually an MRI when he had the pituitary tumor. Right here is where the tumor is. Look how big that pituitary gland is. It should not be that big at all. And the way that they do the surgery, it's awful. They basically go in through your nose and they puncture through your sphenoid bone. See, this is the sella turcica. And the sphenoid bone, you should remember, is quite thin at that region. So it's easy for them to put instruments or tools through that part of the bone, and then they can snip out that tumorous gland. It has complications, of course. Because of him having this procedure, it ended up, they went through his orbit somewhat, and he ended up having a detached retina for a while, and they had to then correct that. It was really just a miserable time for Professor Huska. So earlier, I started to tell you that most hormones are regulated through negative feedback mechanisms. And I would like to just give you an example of that right now. So let's say the hypothalamus wants to tell the anterior pituitary, where the somatotropes are, hey, this body needs to grow. So the hypothalamus releases a hormone called GHRH, and it stands for growth hormone releasing hormone. This is the hypothalamus's way of saying, hey, anterior pituitary, we need some action in this body. So the hypothalamus is now giving permission, that's what we mean by the plus, to the anterior pituitary to release its growth hormone. Growth hormone will stimulate the bone cells or cells found in bone and even in cartilage to increase mitotic rate and osteogenesis. But it also targets the liver. We usually don't think of the liver as an endocrine gland, but it is. It releases another hormone or chemical signal called insulin-like growth factor 1. This has another name, of course. There's always two names for things in anatomy, except for when there's 7. And this is called somatomedin C. So ILGF or somatomedin C. It turns out that there are some people that don't have a functional receptor for growth hormone on the liver, and the liver then does not release insulin-like growth factor, and these people end up having short stature. In particular, those people are called the Laron dwarfs, L-A-R-O-N dwarfs. So those people, there's a population of them in Ecuador. They have very short stature, and it's not from a lack of growth hormone. They actually have sufficient amounts of growth hormone. It's just that they don't have an appropriate growth hormone receptor. It's not functional. And so their liver does not release the somatomedin C, insulin-like growth factor, and they don't grow right. There are also some other people that have short stature, and it's not so much from an issue with the growth hormone or the receptor. These are called the African Pygmies. And if you're interested, you can look these pictures of these people up online. The African Pygmies also have short stature, and it's again not an issue with how much growth hormone they're releasing. That's fine. It's just that the liver is not making the appropriate insulin-like growth factor. Okay, so that's growth hormone. Let's move on to the thyroid gland. Before I move on to the thyroid gland, or the HPT axis, are there any questions? Remember, you can unmute yourself if you have a question at any time.
I do.
Okay.
You have said it multiple times in the semester, and it may not be related, but you keep saying everything has 2 names unless it has 7. What does that mean?
That there's more than one term for most of the anatomical terms that you're learning about.
But what has 7 names?
It's a joke.
Oh. That's funny.
Now you get it.
I got it
Nancy's
before.
having happy hour while watching this. She's been having happy hour, I think.
No, I got it before, but I'm like, I don't know of any organ or any tissue that has 7 names. I'm like, I'm waiting for you to tell me what has 7 names.
Well, there are a couple of times where I've gotten up to as high as 4 or 5 names for the same structure. I'm trying to think of one right now. I'm kind of hard pressed. Usually it's as I'm going through a system and teaching it, I'm like, or it's called this, or it's called this. So for example, the anterior pituitary is also called the adenohypophysis. The posterior pituitary is also called the neurohypophysis.
Okay.
So there are some structures where, when they were first identified by early anatomists, before we had social media, before we had the ability to publish and inform, there were different groups of scientists that would discover something and then name it how they wanted to name it. And it wasn't until they had a big conference or took a ship across the ocean to share their information that they started to say, oh, that's what you call it? We call it this. And then another group said, oh, that's what you both call it? We call it this. And because early on in those days, you couldn't figure out who discovered it first, many textbooks will put all of the names because it might be regional. It might be based on country. For example, adrenaline versus epinephrine. Adrenaline is a European term. Epinephrine is more of an American term. So there are regional differences. And again, it likely stems from groups of people, scientists, physicians, studying something, naming it a certain way. And when they finally got together, they couldn't figure out who should claim rights to it. And now we just kind of give them all credit for it.
Got it.
Yeah.
Thank you.
You're welcome. Okay. So now I am going to start to tell you the rules for some of these hormonal axes that I started to tell you about. Once we learn the rule for one axis, it applies, the same rules apply to the other axes. And to start us out, we're going to learn about the hypothalamic pituitary thyroid axis, or HPT. Now, in my story, I need to start out telling you what happened one morning when the boys were younger. So bear with me, there is a purpose to these stories. Back in the day when I first started at Saddleback, Mac was I started part-time within a month after Mac was born, and he's 16 now. And when I was full-time, he was only about 2 years old. And back in those days, I would be home during the day, pretending to be a stay-at-home mom, My husband would go to work, and then he would come home from work, and I would then have a full teaching load in the late afternoon, evening time. So many times I would come home from work exhausted, and I would not feel like grading exams, mostly because I'd be afraid of making a mistake. And I assure you that there is no rage bigger than when students think that they have been dissed points on exam. I hear from you all. Most of the time you're quiet, but if you think you've earned a point, man, do I hear from you. Like 1 point makes a difference for a grade. No, it doesn't. No, it doesn't. And if you think that's true in this class, well, I'll make you do the mathematical proof that it doesn't make that difference. Anyway, so I'd wake up early in the morning and I would grade, and I would enter the grades into Canvas, let's say. One early morning, I would have to wake up very early because Mac would wake up a little bit before 5. He was very annoying. I could put him to bed at 4:45 and he would sleep for 10 minutes and still wake up right before 5. It didn't matter. It didn't matter. So shortly before 5, I hear him getting out of his bed and the floor creaking. And I knew he was coming into the office. My office is right next door. And I'm entering grades, and I'm entering grades, and I'm entering grades. And he comes into the room, and he would always start, he was just a chatty Cathy. I mean, just talking. And he'd come in and he'd say, "Mommy, I'm going to tell you," and I would say, "Hey, buddy, how'd you sleep?" And he'd say, I didn't sleep." I said, "You didn't?" "Nope, I watched a movie all night long." And then he'd start telling me about the movie he watched during the night. He didn't realize what he was describing were dreams. He thought they were movies and that he didn't sleep. So he'd tell me about all these movies that he watched, and he's talking away. And I'm trying to enter grades. And we had just moved into this house, and the owners left a whole bunch of keys, random keys. And I put them all on a keychain to try and figure out where these keys went to. What lock? Was it a gate lock? What was it? Well, I figured it out except for one. So Matt comes in this morning and he's just talking, and I'm trying to get my work done and not make a mistake. And I decide, I'm going to distract him. So I gave him this keychain, and I held up the key that I didn't know where it went to. And I said, "Mommy doesn't know where this key goes. Can you figure it out?" So I hear him in the office. There's a lock on the office door, and I hear him, and I'm kind of looking over at him, and he's trying to get this key into the office lock. And I had already tried it. So he's trying all these different holes. Then he thinks I should stick a key in there and try and unlock a lock. And he keeps saying, "No, Mommy, it doesn't work here." And I'd be like, "Okay, keep going, buddy, keep going." Next thing I know, he says to me, "I found it, Mommy. I found the lock. I know where the key goes." And I'm typing away, and I'm saying things like, "Good job, buddy. I knew you could do it." Totally placating him, not really listening to him. "Mommy, yuck," he says. "Mommy, yuck." He couldn't say his L's. "Mommy, yuck it." And he finally comes over and he grabs my head and he turns my head to look where this key is. And he has inserted it into the electrical outlet. And I'm looking at him trying to figure out how in the heck he's not electrocuted. And it occurred to me that I was parenting in all the wrong ways. I assumed that my children, my oldest at the time was 6, and I assumed that my children, my angel children, would never do anything wrong. They would never do anything in general unless they asked me first. And boy, was I wrong. Clearly, Mac needed to be told that you shouldn't stick keys into electrical outlets. So it made me pause, and I thought, what else should I say to my children to tell them definitively, no, you won't do this unless I say it's okay? So I went through a whole list of things like, no, you will not cross a street unless you are holding mommy's hand or daddy's hand. You will not until you have my hand. So I was going through this, and I want you to think of me parenting as the hypothalamus. I am the first organ. I am the first gland. I am going to release a signal. I'm either going to say, no, you can't, or I'm going to say, yes, you can do this. Those are my commands. If it's a yes command, I am saying, release. You can do it. So when the hypothalamus gives a yes command to the pituitary, it will release a releasing hormone. It's releasing the pituitary to say, you can do this now. If the hypothalamus is telling the pituitary, no, absolutely not, and I mean no, it releases an inhibitory hormone. Let me show you an example. I told you about growth hormone releasing hormone. That is a hormone giving permission to the pituitary to release growth hormone. If the hypothalamus could talk to you, it would say, growth hormone releasing hormone is my way of saying to the pituitary, now is a good time for the body to grow. Now is an acceptable time for the body to grow. But somatostatin, Nancy, has another name, and it's called growth hormone inhibitory hormone, GHIH. And growth hormone inhibitory hormone released by the hypothalamus is basically the hypothalamus saying to the anterior pituitary, oh, hell no. Oh, no, no, no. Now is not an appropriate time to grow. Now is not. And a lot of students say, wait, Kara, what time is it when it's not appropriate to grow? If you are under severe stress. Children, in fact, that are malnourished, calorically deprived, physically abused, emotionally abused, to get through those stressful times, they require energy, fuel, and growth requires fuel. So if the child is under stress or malnourished, that would not be an appropriate time to grow. Hold on, please. All right, I'm back, sorry. So there are times where it's inappropriate to grow, where your resources are few. Right now though, Kennedy, now's not the time to turn to your parents and say, I knew you were abusing me. That's why I'm not 5'8". That's not appropriate. You can't turn to your parents and say, you're to blame, you abused me, this is why I'm not as tall as I want to be. But children who are abused do have short stature. And I remember a neighbor of ours, 4 boys, and the third boy was a lot smaller than his two older brothers and even his younger brother. And this child went through a lot of psychological issues from a second grade teacher that abused him, verbally abused him in school. I remember being in lineup, watching him vomit on the asphalt because he'd be so scared to go into the classroom because the teacher would pick on him incessantly. And the only reason why I knew that was happening is because the room mom who would volunteer reached out to me and said, I know you're friends with his parents. You need to talk to them. He is being preyed upon. Those were her words. He's being preyed upon by the teacher. No 7-year-old child should be afraid to go into a classroom. And to make matters worse, his own brothers picked on him. To make matters worse, his mother was she was not into parenting. She wanted the girl. She didn't get the girl. And if Jared didn't eat when she wanted them to eat, she would take away his food. It was just awful. It was just awful. This child had problems with bedwetting until he was in his teens. He was just under a lot of stress, and his dad thought he could make it better by putting him on a competitive sports team. No, competitive. I mean, this kid ran like he was a gay T-Rex. He would just be like running like this. That is not where you put a child on. You just don't do that. And the coach would scream at him. I mean, this child is short to this day. Thankfully, he is thriving in college. He is doing well, but he went through a lot of psychological stress. So there are inappropriate times for growth. Let me summarize. I am Mama Hypothalamus. I am going to give commands to the anterior pituitary. I will either release a yes, saying now is okay, then the hormone I want the anterior pituitary to release will be, in this case, growth hormone releasing hormone. I am telling the pituitary, release your growth hormone. Or I give a no command. Growth hormone, inhibitory hormone. I am telling you, anterior pituitary, you cannot release your growth hormone. Now is not an appropriate time. Sometimes the pituitary behaves like a mature child. So I want you to think of the pituitary as the child that needs to be told what to do. But sometimes the pituitary can be that child that says, I know, mommy, I know. I've learned when it's appropriate. So sometimes the anterior pituitary knows not to do something, that the default is no until I say yes. And that's how I was parenting my kids. I assumed they wouldn't do something until I said yes. So some of the hormones released by the anterior pituitary need strict regulation. They need to be told, yes, you can. And then if it's not yes, they are told absolutely not. Some hormones released by the anterior pituitary are the older child, and they know not to do something unless told it's okay. Most of our focus will be on the hormones that are going to respond to a yes command. Yes, you can do this now. So that being said, let's go back to our HPT pathway. It's the hypothalamus, anterior pituitary, thyroid gland. The thyroid gland is a butter-shaped gland in the anterior region of your throat, just below your thyroid cartilage or your Adam's apple. So your thyroid gland is found just below it. If you go to the physician, they frequently are feeling your throat, and that's because they're palpating your thyroid gland. If your thyroid gland is too big, they can feel that. And in enlarged thyroid gland, we say you have a goiter. Perhaps you've heard of that term before. So a goiter is an enlarged thyroid gland. It is the most pure, or I should say, the largest pure endocrine gland. So it is not exocrine at all. It is just endocrine. And it has these two butterfly wings connected by a narrow portion called an isthmus. Histologically, the thyroid gland is found in your lab histo packet number 4. Histologically, we see these repeating circular structures. This entire repeating circular structure is called a follicle. The purple cells that you see around the light pink center are called follicular cells. The light pink center is called, has a protein called thyroglobulin. Thyroglobulin is a protein made by the follicular cells, and they exocytose it into this middle space here. So that's the lumen. Another word, Nancy, for a solution that is high in protein content is called colloid. So next time you have chicken noodle soup, for example, where there's a lot of chicken in the soup, you can say, instead of saying this is delicious chicken noodle soup, you can say this is delicious colloid soup. A lot of protein in it. So the thyroglobulin, being protein, is put into this space, and we say that it is colloid. That's just a generic term to say a solution that has a lot of protein. So the follicles, the follicular cells of the follicles, make the thyroglobulin. Thyroglobulin is a precursor. It's going to be modified into 2 different thyroid hormones. There is a variety called T4, Nancy, there are 2 names for everything except for when there's 7, is my joke. T4 is also called thyroxine, and it's also called tetraiodothyronine. So there you go. There are 3 terms for this variety of thyroid hormone. T3 is also called triiodothyronine. Tetra means 4, tri means 3. Well, what is there 4 of? What is there 3 of? You will see that there are either 4 iodides or 3 iodides attached to this amino acid. And I will explain that in just a moment, show you a picture of it. There are other cells in between the follicles. Let me use a different pen color here. So there are other cells in between that I'm trying to color in blue that are next to the follicles, and those are called parafollicular cells. They make a totally different hormone called calcitonin, which we learned about in our bone chapter way back in lecture unit 1. Calcitonin really has negligible activity once you're born, but when you were developing in utero, it basically decreased your calcium levels in the blood because the bones would be taking up the calcium to start modeling bone. So when you were developing, remember most of your bones are created from cartilage as a precursor, and then it goes through calcification and then osteogenesis. So calcitonin was important for the osteoblasts to take the calcium and start depositing bone back when you were developing, and all of that came from your parafollicular cells. So here is another picture of your thyroid gland on the anterior portion of your trachea with the isthmus in the middle. Histologically, we see these repeating circular structures called follicles. The follicular cells line the center region, which is filled with colloid, specifically thyroglobulin. So here's thyroglobulin. It is a large protein that gets pushed into this lumen space. So here's the lumen. This would also be the lumen, the middle, where the colloid is. It's a long protein chain of like over 3,000 amino acids. And one of the amino acids that is repeated a lot in that chain is tyrosine. And tyrosine has a ring. I'm trying to draw a hexagon, which is very set. Burp. My styloid is not doing what I want it to. Anyway, it's got this ring. And attached to that ring, we start to see iodide. And as the thyroglobulin is exocytosed, iodide, shown here as the anion, is attached to the tyrosine residues. If only one iodide gets attached, it's called monoiodothyronine. If two get attached, we call it diiodothyronine. Mono and diiodothyronine, those are not useful to us. But if three get attached, it's called triiodothyronine. And if four get attached, it's called tetra. So the thyroglobulin actually has to exit the cell and go into this colloid space because there is an enzyme just outside of the cells facing the lumen whose job it is to put on the iodide. This is why you need iodide in your diet. This is why they iodinize salt. So this enzyme is found on this side, the apical side of these follicular cells, and it's only when they exocytose thyroglobulin that the iodide is placed on. Then the cells have to drink that protein back in. They endocytose it. And then they chop up the protein and they release into the bloodstream only the tyrosine residues that have either 3 iodides or 4. Both T3 and T4 together are known as your thyroid hormone. When they draw your blood, they are most certainly assessing your thyroid hormone levels. So T3 and T4, let me tell you a little bit about them. Which one is released most abundantly into the bloodstream? T4. About 80 to 90% of your thyroid hormone is the T4 variety. But which one's active? Which one do the cells of your body respond to? T3. So T3 is the active form. T4 is a preliminary form. Once your cells of your body use T3, all they have to do is remove an iodide from T4 and, well, 4 iodide minus 1 gives you 3. So think of your T4 as your time release form. What was I going to say? I just lost my train of thought. Just had a random thought. Having a party in my head. Give me a moment. Oh, target cells. What are the target cells of thyroid hormone? Every single cell in your body is the target cell for thyroid hormone. Every single cell. Every single cell. Even brain cells are a target for thyroid hormone. even your heart, even your gonads, testes, ovaries. What does thyroid hormone do then if every single cell in your body is a target cell? That should speak volumes to you. Thyroid hormone clearly is a very important hormone then. Agreed? Very important. There's a reason why they measure this every time they draw blood from you. Every time they draw blood. And when you get to be my age, they even do a bigger panel of analysis for thyroid hormone. We even do this in animals, don't we, Sarah? Yeah, she's nodding. Yes, yes. Look, thyroid hormone targets every cell in the body, and thyroid hormone is considered to be permissive. Let me explain what that word means. No other hormone in your body will work correctly if you do not have adequate amounts of thyroid hormone. No other hormone will work correctly. Thyroid hormone is huge. I mean, it's not like big in size. It's huge with its dominance in your body. Women who are having problems conceiving, first thing they check is not their estrogen and progesterone. Nope, it's thyroid hormone. They check first to see that that woman has adequate amounts of thyroid hormone, because they know if she doesn't, if she is hypothyroid, her ovaries will not respond to the hormones released from the anterior pituitary called luteinizing hormone and follicular stimulating. Her ovaries will not work right. She won't ovulate correctly. She won't have a menstrual cycle that is regular. A child that's not growing, we don't look at growth hormone first. We look at thyroid hormone first. Diabetic, we check thyroid hormone. Yeah, we're going to still look at insulin, but we're going to also look at thyroid hormone. Maybe they won't need insulin. Maybe it's a problem with their thyroid, and we should address that. Then the pancreas will be fine. It's permissive. It gives permission for every other hormone in your body to work correctly. Without it, there is no permission. It's huge. It is clinically important. And this is the reason why I invited you all to join me for this lecture. Even though our class is hybrid and technically lecture is online, this is a clinically important lecture, and we go after it fiercely in physiology because it's clinically relevant. So every cell in the body is a target cell for thyroid hormone, and every cell will respond to thyroid hormone according to its gene expression. If you have thyroid hormone levels that are too high, guess what your heart does? If you have too much thyroid hormone, your heart beats with faster rate and greater force of contraction. It also stimulates your neurons. People with hyperthyroidism, they complain that they can't fall asleep at night because they can't turn their mind chatter off. They're thinking a mile a minute, they say. Their heart is pounding so hard it feels like it's coming out of their chest. They basically feel like they're having a 24/7 sympathetic response. That's how they feel, but it's not from epinephrine. It's from thyroid hormone. It causes increased gut motility if you have too much thyroid hormone. If you've known someone who has had hyper meaning too much thyroidism, too much thyroid hormone, they have increased gut motility. They have raging diarrhea. They lose weight. And they'll say, I eat and eat and eat and I can't gain weight. And you're like, oh, poor baby. I assure you, this is not something you want. I had a student that in order to lose, she wanted to lose weight. She started to take thyroid hormone extract, but not from human, from horse. She went across the border into Mexico and she got horse thyroid hormone extract. Once she stopped that, she paid dearly. Taking that extract messed with her HPT pathway and ruined it. This is also the cautionary note I told you why you should not take growth hormone unless directed by a doctor. You do not mess with your HP whatever axis. Do not mess with it. And I'm going to teach you why. I'm going to teach you how that axis works. It is fine to, there's nothing to mess with unless it fails. And if it fails, then a doctor is going to help you correct compensation, the medical intervention to get you back towards set point. But you do not do this on your own. No. No. I'm Mama Hypothalamus. This is me telling you inhibitory hormone. No. So what about the signs and symptoms of hypothyroidism? Too little. What does the person look like if their cells are not being stimulated? You know why? You know who usually comes in to complain about hypothyroidism? Women. They come in. Usually what drives them to seek medical intervention is because their loved ones and friends say, you're not thinking right. You're not behaving right. You're not right in the head. And it starts to create relational problems. And the reason why they're not right in the head is because the lack of thyroid hormone, they don't have proper neuronal activity. They're not processing reality the same. They're not logical in thought. And those around them are like, you need help. The other thing that drives them in is the weight gain. Very frustrating. They'll come and say, I'm exercising, I'm watching what I eat, I hardly eat, and I still am gaining weight. They also will have sleep problems, but the opposite kind. They're going to be sleeping too much. They have what we call increased somnolence, excessive sleepiness. They sleep 8 to 10 hours a day and they still wake up and they're exhausted. And that's, again, everyone around them is like, you're a little weird. Maybe you're depressed. Is that why you're sleeping so much? You need to go see a doctor. So it's usually the interpersonal relationships that are being compromised because the excessive sleepiness, not thinking right, and everyone starts to think they have a mental health disorder, when really, could be the thyroid. Your hair starts to fall out if you don't have enough thyroid hormone. A lot of beauticians that do hair, they're the first ones to know. They know to check that. They'll say, wow, your hair's really thinning. Have you had your thyroid checked recently? My hairdresser would say that to me from time to time. I think you should go in, Kara. So signs and symptoms: hyperthyroidism, weight loss, diarrhea, can't sleep because of the mind chatter, the neurons are activated too much, the heart pounding, they're hot all the time. Hot, oh, I'm so hot. I just can't tolerate. Is it hot in here or is it me? Yeah, it's you. Signs and symptoms of hypothyroidism: excessive somnolence, they're sleeping all the time, not able to process reality or think correctly. They're cold all the time. Decreased gut motility, might be constipated, excessive weight gain. So thyroid hormone does a lot to your body and it needs to be finely regulated. We don't want to be at those extremes. We don't want to have constant mind chatter and a sympathetic feeling. And we don't want to be slow and sluggish and have all this weight gain when it's a hormonal problem. So now I'm going to teach you how this pathway is regulated. And I, again, am going to tell you a story to help you with this. I am Mama Hypothalamus. I am again going to use my boys as an example. McLean, the youngest, he will be the adeno hypophysis. He will be the anterior pituitary. My oldest in this story, Hayden, he is going to play the role of the thyroid gland. So first, the story. Back when I first started at Saddleback, and I'd be the stay-at-home mom during the day, but then go to work at night, I would I would pick up Hayden from school, and the rule in our house is when you get home from school, you can have a snack, but then when you're done with your snack, you are upstairs and you are doing your homework. You cannot watch TV, you cannot play outside, you cannot go to your sports team practice until homework is done. That's the rule. So Hayden would have his snack and he'd go upstairs to his room and he'd start his homework. Meanwhile, and this is like he was in second grade, third grade, so he could do a lot of it on his own. He didn't really need me, but I would check on him, and here's how I would check on him. Mac and I would be downstairs getting dinner ready so that when my honey came home, dinner was ready. He didn't have to worry about anything. And I was just tag team. He's got the boys. He would do bath time and stories and practice, soccer practice, and I would go to work. So Mac and I would be downstairs making dinner, and Hayden would be upstairs working on his homework. Every once in a while, I would need to check on Hayden to make sure he was okay with his homework. But I have the oven on. I have the stove on. I can't go upstairs and leave a toddler downstairs in the kitchen on his little helping chair, hovering over these hot areas, potentially burning himself or scalding himself. I can't have that. So I would pick Mac up off of his little helping chair, and I would say to him, I need you to go upstairs and I need you to check on Hayden. How's he doing with his math homework? What's going on with his math? Is he almost finished with math? And Mac would I'd put him down on the floor and I would watch him walk across the room, get to the stairs, and I'd hear him take one stair at a time because he had little legs. And I'd hear him open Hayden's door, bedroom door, and close it. And silence. And I'm downstairs waiting. Finally, the silence is going on for too long. And as a parent, those of you who are parents, you know when there's silence, nothing good is coming from that. You need, something's going on. But I'm stuck in the kitchen with hot, boiling water. So I would yell at Mac, McLean, get down here. And I'd hear Hayden's door open and close, and Mac would come down the stairs, and I'd pick him up and put him back on his chair, and I'd say, so how's Hayden doing? How's his math? He's not done yet, Mommy, he's not done. And I'd repeat this from time to time. Mac, go check on Hayden. And he'd go upstairs and he'd report down to me. Now, when is this going to stop? When am I, what was that, Sarah? Not when dinner's cooked, no.
When the homework's done.
Exactly, when the homework is done. That's my end game. That's what I want to see. So again, I am Mama Hypothalamus, Mac is the pituitary, and Hayden is the thyroid. I am stuck in the kitchen. I am stuck in the cranial cavity. All of these glands technically are stuck in their place, but they can signal each other. So I gave a command to Mac, and my command was go check on your brother. The command that the hypothalamus gives the pituitary is called thyrotropin releasing hormone, TRH. That's the permission. Hey, releasing hormone. Hey, anterior pituitary, I need you to check on this. I need you to signal the thyroid gland. I need you to tell the thyroid gland, hey, we need the homework. So Mac, being the anterior pituitary, he goes and communicates to Hayden and says, Mommy wants your homework. So the anterior pituitary releases thyroid stimulating hormone. Its name tells you what it's going to do. It's going to stimulate the hormone. Think of Mac putting the fire under Hayden's ass by saying, Mommy wants to see your homework. Where are you? And the thyroid gland is going to release thyroid hormone. That's the homework I want to see. So when the thyroid gland finally gets the signal, the command, it should release thyroid hormone. It will target all the cells in the body. Now, in my story, I heard myself speak to McLean. I saw him walk across the room, I said. I heard him walk up the stairs, and I heard Hayden's door open and close. I knew from those things that Mac heard my command and acted on it. But the hypothalamus does not have eyes, does it? It does not have ears. It does not touch. It cannot smell. So how does the hypothalamus know how much hormone, releasing hormone, it released? How does it know?
Receptors.
Exactly. So I'm using blue ink. These dots I'm drawing are the thyrotropin releasing hormone. The anterior pituitary has receptors, of course, for that hormone. Remember, hormones go into the bloodstream and they are distributed everywhere in the body. This TRH is released into the hypothalamic hypophyseal portal system, the first capillary bed. It travels a short distance and it binds to the receptors in the anterior pituitary. When the anterior pituitary has its receptors populated, that's how the anterior pituitary knows that the hypothalamus gave it a command. The hypothalamus needs to know how much of a command. I mean, again, it can't smell, it can't touch, it can't hear, it can't see. So some of that hormone also goes through the entire blood supply of the body and comes back and populates receptors on the hypothalamus. So the hypothalamus is also a target for its own hormone. When all of its receptors are bound, that's how the hypothalamus knows it gave a command. As I watch Mac go upstairs and hear him open Hayden's door, do you think it's a good use of my energy to keep screaming at that child? If he's already obeying my command, should I say, and I made it, get going, let's go, let's go, let's go? That's a waste of energy, especially if the child is already responding to me. So the very hormone that the hypothalamus releases goes to the anterior pituitary, but also feeds back and inhibits the hypothalamus, as if to say, hey, mama, you gave a command. Don't keep screaming. Let's see what happens. I see examples of this a lot when I'm out walking at grocery stores, back when, when people were allowed outside. I would see parents reprimand a child, and clearly the child gets it, gets the command, understands, and the parent keeps screaming at them. Why? That's a waste of energy for the parent, and then the message is definitely lost in all the screaming. It's just it's bad parenting. Keep it simple. And that's what the hypothalamus does. Releases the hormone. Some of that hormone goes to the target, the anterior pituitary, but it also feeds back to the hypothalamus, populates the receptors, and that's how the hypothalamus can quantitate how much of a signal it gave. That's how it knows it gave a signal. So then the anterior pituitary releases TSH that I'm drawing here in red. And that circulates through the bloodstream. And of course, the thyroid gland has receptors for TSH. Of course it does. But so does the hypothalamus. And that's how the hypothalamus knows that the anterior pituitary obeyed the command. It too has receptors for TSH. And the anterior pituitary also has receptors for its own hormone. And that's the way the anterior pituitary, if it could talk, would say, I'm such a good child. I obeyed mommy's command. I know I did. My receptors are bound. So because of this hormone, TSH, being circulated, it is also feeding back and telling the hypothalamus, hey, not only did I get your signal, I'm obeying it. And again, should I be barking at McLean if he's already obeying my command? I shouldn't keep barking at him. I shouldn't keep screaming at him. And similarly, the anterior pituitary should not keep releasing TSH if it's released enough, where all of its receptors are bound. Enough is enough. Give it some time. Let's see what the thyroid gland does. So when the TSH receptors bind TSH on the thyroid, the command is now for the thyroid gland to release thyroid hormone, which I'm drawing here in green. And the cells of your body, all the cells of your body, have receptors for thyroid hormone, including, yes, the thyroid gland itself. And that's how the thyroid gland knows that it got its message from the anterior pituitary and obeyed. The anterior pituitary also has receptors for thyroid hormone, and the hypothalamus also has receptors for thyroid hormone. And that is the feedback that the hypothalamus is waiting for. That's the homework Hayden is bringing down to me. Do you think it's appropriate if Hayden brings me his homework and I scream at him, what? Just tonight's homework? Where's the entire month's work of homework in math? That is not okay. That is not okay. So this long loop, this is what we call the long loop. From the thyroid gland back to the hypothalamus, that is the negative feedback inhibition I need. Hayden comes down with his homework. That should shut me up. He's done what I asked. I don't keep screaming at him. That is called negative feedback inhibition. I am getting feedback from a downstream gland, and it's basically telling me you need to close her down. Negative feedback inhibition. These other two over here that I drew in blue and red are short loops of negative feedback inhibition. So let me show you that again on these slides. Here is the long feedback inhibition. That's ultimately what the hypothalamus wants to see. It will stop barking. It will stop releasing thyrotropin, releasing hormone, if it gets all of its receptors bound by thyroid hormone. So when all those receptors are bound by thyroid hormone, again, I drew that in green on the previous slide, the hypothalamus should then stop releasing thyrotropin releasing hormone. And if it stops releasing TRH, what do you think the anterior pituitary should do? It should stop releasing TSH. If I don't tell Mac to go up and check on Hayden, he should not be going up and checking on Hayden. And if the TSH levels go down, what do you think? Oops, didn't draw that in blue. What do you think the thyroid gland should do? Stop releasing thyroid hormone. So if the thyroid hormone levels start to decline, guess what happens to the receptors for thyroid hormone on the hypothalamus? They are no longer populated. And when they aren't populated, that's the trigger to tell the hypothalamus to release TRH again. We got to get the system going again. Then that means the anterior pituitary will release TSH. And then that means the thyroid gland will release TH. And then the receptors are populated again. And that in turn shuts everything down again. So this axis is constantly cycling through rev everything up, shut everything down. Rev everything up, shut everything down. It's constant turnover and feedback. Again, there are short feedback loops. I demonstrated that here. Here's my short feedback from the anterior pituitary feeding back to the hypothalamus and the TRH feeding back to the hypothalamus. Those are short feedback loops. Those short feedback loops are not as powerful as the long feedback loop. That one has the ultimate control. That's the one that the hypothalamus relies on the most. Now, let's play. What, Sarah?
Is this, that whole, all of that cycle though, is considered negative feedback?
Correct.
Okay.
Negative feedback inhibition.
And I know there's not much, our body mostly does negative feedback. It's not positive feedback, except like the breastfeeding stuff and all that. And that wouldn't be a system like this, right? A positive, I know we don't actually probably need to focus on it that much since it's small, but.
Positive feedback would be if the hormone led to the release of another hormone, which fed back and led to even more, which leads to, and in positive feedback, here's my demonstration. Okay, you ready? Here's your variable at set point. With positive feedback, the deviation and the correction go in the same direction, which means you're getting further away from set point.
Right.
We use positive feedback in very few examples because we're really allowing a variable to get way out of normal range. But all positive feedback mechanisms must ultimately be stopped with a negative. And negative feedback means the deviation and the correction go in opposite direction.
Right.
Look,
okay.
you get too hot, what does your body do? You start sweating. That cools you off. You take off layers if it's socially acceptable. You sprawl, and that increases surface area to allow for more evaporation and sweating. If you get too cold, what is the appropriate response? You curl up in a ball, you put on layers, you start to shiver, which generates heat. So you get too cold, your body corrects by generating more heat until you get back toward your set point. That's negative feedback. Positive, deviation, correction, deviation, correct. Deviation and correction go in the same direction, and ultimately you're going to have to come back.
Yeah.
If there isn't a healthy negative feedback to reset, the ultimate negative feedback is death. You will die.
Okay.
Women do die during labor.
Yeah.
Especially if the labor fails to progress or we can't birth the baby. Eventually, that will exhaust the mother.
Right.
Eventually, the baby will probably die in utero, leads to sepsis. I mean, it's no bueno.
Right.
Yeah. Okay. So let's go through some clinical applications. Clinical applications. There are people you will encounter that have thyroid dysfunction of some sort. They will either have hyperthyroidism or hypo. Where's the culprit? Which gland is the culprit? How do we correct this? Look, you learned a little bit about anemias back in lecture unit 2. You learned about iron deficiency. You learned about vitamin B12 deficiency. I gave you a few samples of anemia. We have ways to figure out what kind of anemia a person has. Figuring out what caused the anemia dictates how we help. Makes no sense to give someone an iron pill if they have vitamin B12 deficiency. That's not going to help them. Someone who has vitamin B12 deficiency, giving them an iron pill is not going to help them. Someone with iron, giving them vitamin B12 is not going to help them if they have iron deficiency. Figuring out the etiology, the source of the problem, dictates how we help in medicine. So same with hyper and hypothyroidism. Which gland is the culprit? We got to figure this out. So I'm going to go through some practice problems of what you can expect on your lecture exam for Unit 4 for the endocrine system. And I encourage you to save these notes. If you think you're going to take physiology at Saddleback, you're going to want to save these notes because you're going to see these slides all over again. Okay. We are going to play with a diseased state. Over on the left side, we have a thyroid gland. That's our gland that is overactive, too much. So that would be your hyper, agreed? And over here, we have a thyroid gland that has too little activity, and that would be your hypo. So you have a patient come in, and they have all the signs and symptoms of hyperthyroidism. They're complaining of diarrhea, weight loss, can't sleep at night, pounding heart, feeling anxious and nervous. My slide tells you that the thyroid gland is the culprit, okay? I'm telling you which gland is the culprit. Then that's where you start. So come down here, and on this left side, let's fill in what we would expect to see for these hormone levels. I want you to use arrows, either up or down, to describe these hormone levels compared to normal, compared to set point. None of these are going to be at set point. We're in a diseased state. I want you to tell me, will these hormones be too high or too low compared to normal? Our thyroid, we are told, is the problem. So you start down here. If it's too much, tell me what will happen to the levels of TH. Just use your fingers. Sarah's saying up. Yeah, the thyroid is over secreting. Okay, now you have to feed back to me. I'm Mama Hypothalamus. My receptors are going to be very populated, aren't they? All that thyroid hormone in the bloodstream, my receptors are going to be very popular. All of them are going to be full. And if Mama Hypothalamus could talk to you, it'd be, oh my gosh, I didn't tell. What are you doing? That's like Hayden coming downstairs with 3 months worth of math homework done, and I didn't tell him to do it. I'm going to be taking those pages and going, child of mine, go outside and be normal, Sheldon. So what am I going to do? What should my hormone levels do? Go down. I'm trying to put the brakes on this. What should the TSH levels be then? Also low. But the thyroid gland is not obeying. The thyroid gland is not obeying. It's not obeying the chain of command. This now is negative feedback, inhibition, failure. The chain of command is not being obeyed. The thyroid gland is going rogue. Now let's do too little. The thyroid gland is not producing thyroid hormone. So what would those levels be like compared to normal? Down, obviously. Well, then what's going to happen to my receptors on the hypothalamus, sorry. They're not going to be populated, are they? You know what that's like? That's like Hayden up in his room playing his Xbox and going, I'm not doing math. So I'm going to scream, aren't I? I am going to rage. And what am I going to do to Matt? I'm going to scream at that anterior pituitary. You better get this going. You better go tell your brother. What do you think the TSH levels will be like? But again, we're told the thyroid gland is the problem. And we're not getting the response. This is again, negative feedback, inhibition, failure. Now I want you to look at those arrows and save them on your own notes, okay? Okay, because we're going to come back to these. Let's move on to another scenario. In this scenario, Mac, the anterior pituitary, he has gone rogue. And again, on our left side, we have too much activity, and on the right side, too little. Again, my slide tells you which gland is the culprit. And that's where you start. So, MAC is the culprit, and we have, let's do the too much column. So tell me what is happening with TSH. What are the levels for too much? Obviously, oops, too high. Too high compared to normal. That's our starting point. This is like Mac going upstairs secretly to Hayden's room and screaming at him going, Mom said you have to do 3 months homework. Hayden doesn't know. He doesn't know that it technically didn't start with me. His brother's just being a little shit, but he doesn't know. So what is the thyroid gland going to do being obedient? TH levels go up. Feedback to Mama Hypothalamus. What's going to happen to my receptors? They're going to be populated. So what should I do? My hormone levels. I'm going to try and put the brakes on, but McLean is going rogue. So this is, again, negative feedback inhibition. Do you see on this slide and the previous one that the thyroid hormone levels on the left side for both this slide and the next is high? These two people, different scenarios, have hyperthyroidism, but for very different reasons. Very different reasons. That's like saying someone can be anemic for very different reasons. And we got to figure out, what is the etiology? Where is the culprit? Let's do too low. This is like me saying to Mac, I want you to go upstairs and check on your brother, and Mac goes and hides behind the couch, pretends that he's going upstairs. So this is where we start. Well, what will happen to TSH levels? Goes down. Hayden's upstairs saying, yeah, no one's checking on me. I guess I don't have to do homework. So what will happen to TH levels? Go down. Feedback. Mama hypothalamus, her receptors are not going to be populated, and she is not going to be happy. So what will my hormone levels be like? Up. And this is, again, negative feedback inhibition failure. This negative feedback system is failing to adjust and correct. You've got a gland going rogue and doing what it wants to do. So this person, like the previous slide on the left side, has hypothyroidism, but for a very different reason. There's a different etiology. A different gland started this mess. What about this scenario? What if someone has a hypothalamic tumor that is over-secreting TRH? Well, that's our starting point. TRH goes up, TSH goes up, TH will go up. And even though all of my receptors would be populated, it's not putting the brakes on me. I continue to scream. And again, this leads to hyperthyroidism, but for a different reason. What about too little? A hypothalamic tumor where the tumor impairs the hypothalamic activity. Well, then TRH goes down. TSH goes down. TH goes down. And my receptors would not be populated. That should be the stimulus to get me revved up again, but it's not. This is, again, negative feedback inhibition failure. And again, like in the previous two examples on the right-hand side, this person would have hypothyroidism. You know what, my sweets? If we suspect you have hyper or hypothyroidism, we draw blood. And we look at all three of these hormones. And based on their unique signature, look at this. Did these arrows on this slide match the arrows on this slide or on this slide? They didn't. They might have had the same outcome, hyper or hypo, but the arrows being up or down for each of those three hormones had a different pattern. There was a different pattern. And all we have to do is draw blood, send it to the lab. We can quantify these hormones. It's not hard to do. Hell, they're doing the same technique now to find out if people have antibodies against COVID. These tests are not hard to do, and they are cheap. I don't care what the president says. I am telling you, they're cheap. They're not hard to do. It's just having the resources to do them is the issue. We can go after the organ that's causing the problems if it's easy to get to. If it's not, then we have to do a different workaround. For example, if you've got a tumor in your hypothalamus, we cannot remove your hypothalamus. You will die. You know that, right? We can't remove it. We can do other things like radiation, but we can't remove it. But I can remove your thyroid gland. I can remove that from your body and you can live without it. So we have options. We like to know which gland caused the problem. We address that if we can. If we can't, we have a workaround. We can, in the case of hyper, we can take out the thyroid gland. We can take it out. If we take out the thyroid gland, we don't have a problem with hyperthyroidism anymore. And then you might say, well, Kara, then the person will become hypothyroid. Yeah, they will. Guess what? We got a solution for that too. The solution for that is called Synthroid. Synthetic thyroid hormone, basically. So it's hormone replacement therapy. We can give the person medication, get their thyroid hormone levels up through this exogenous pill that they take, and then everything will balance out again. It's what we can do. We can surgically remove the thyroid gland. We can also chemically ablate it, destroy it with radioactive iodide. It just depends on the comfort zone of the patient and what they want. Here's a unique situation. Graves' disease. Graves' disease is an autoimmune disorder. That means the person's immune cells are basically mucking with this axis, this chain of command, and disabling it. In this case, antibodies called TSIs, thyroid stimulating immunoglobulin. Immunoglobulin means it's an antibody. What happens is these antibodies, TSIs, antibodies made by B cells, a type of lymphocyte that shouldn't be around, the antibodies go and they bind to the TSH receptors. And the thyroid gland, the poor thyroid gland, its receptors are populated. That's all it knows. That's all it knows. And if the receptors are populated, the command to the thyroid gland is, you better release thyroid hormone. The thyroid gland does not have eyes. It can't, those follicular cells can't peer out and look at the receptors and go, oh, you're silly. You're not official. You're not TSH, you jokester. Get out of here. Can't do that. Has no, its receptor is bound. That's all it knows, and it better obey. So the TH levels, T3 and T4, they go up. And look at this woman with Graves' disease. She's got a big thyroid gland because her thyroid gland is being overly stimulated on these TSH receptors. If the TSH receptors are overly stimulated to the thyroid gland, it means one thing: go dog go. I got to make more. And the follicular cells get bigger. And not only do they get bigger, they replicate and divide. They go through mitosis, and here comes your goiter. So anytime TSH receptors are bound excessively on the thyroid gland, you're going to get a goiter. A goiter is not a diagnostic tool. Let me say that again. If you have a patient come into your clinic and they have a goiter, you cannot say, aha, you've got hyperthyroidism. Nope. Because I'm going to show you on the next slide that someone can have hypothyroidism and still have a goiter. So I'm going to say it again. Any time the TSH receptors are overly populated, overly stimulating the thyroid gland only sees that, knows that as, I got to make more. I'm being told to make more. It's obeying the command, it thinks. That's how it's behaving. Upstream feedback, mama hypothalamus is going, what? I didn't do that. So TRH levels will start to come down. TSH levels will start to come down. And guess what? We can draw blood and we can do a simple test to find out if this person has thyroid stimulating immunoglobulins. The only help for this person is to take out the thyroid gland. We cannot remove the antibodies. We can't. They're around for life. So take away the target. And yes, eventually this woman will have to be put on hormone replacement therapy. What about hypo? What about hypothyroidism? Well, Hashimoto's disease is another strange one. It is also an autoimmune disorder. It's an autoimmune disorder. Graves' disease is too. But in this case, antibodies destroy the thyroid gland. Destroy it. So as the thyroid gland gets destroyed, what happens to TH levels? They go down. We'll feed back to mama hypothalamus. Mama hypothalamus is not going to be happy with that. So TRH levels are going to go up. What will happen to TSH levels? They will also go up. And now, the remaining thyroid tissue that's left, that hasn't been destroyed yet, is being bombarded with a lot of TSH. And that remaining tissue, those follicular cells are going to get bigger, and they just can't do the job because all of their fellow follicular cells have already been destroyed. Here is a woman with Hashimoto's, and you can see her goiter. The remaining thyroid tissue she has left is being bombarded with TSH, but she doesn't have enough thyroid tissue to satisfy the body's requirements. She is hypothyroid. This woman over here has iodide deficiency. She has what we call an endemic goiter. Thyroid hormone T3, T4, I told you, requires iodide. If you do not have iodide, do you understand you cannot make thyroid hormone? Let me say that again another way. Let's say you want to make chocolate chip cookies, okay? But you don't have chocolate chips. Oh, you can make a cookie, but you damn well better not call it chocolate chip. If there's not a chocolate chip in it, it's not a chocolate chip cookie. So if you don't have the ingredient, iodide, then you can't make thyroid hormone. And that means mama hypothalamus, her receptors are not populated. TRH levels go up. TSH levels go up. And now you've got those follicular cells that are being stimulated, but they don't have the proper ingredient. And that person will be hypothyroid as well. This infant has cretinism. If someone calls you a cretin, that's not a nice term to be called. They're basically telling you that you're an idiot, that you do not have adequate mental capacity. I can think of some people in leadership right now that I would want to call a cretin, but I will not. But this baby has mental deficiency because mom had hypothyroidism that wasn't corrected. Maybe she's in a part of the world where she doesn't have adequate health care, and she was hypothyroid and she was pregnant. Thyroid hormone from the mama crosses the placenta and is very important for proper neuronal development. Didn't you hear me say that thyroid hormone is permissive for everything? And when it's a developing fetus, we need mama's thyroid to be functional because her thyroid hormone is going to be permissive to the development of her fetus's brain tissue. So there's no correcting this. We can't give the baby thyroid hormone and suddenly, poof, it's going to grow these neurons. We've missed the opportunity. This baby will not have the mental capacity for life. And how bad will it be? It depends on how bad mom's hypothyroidism was. Oh. That's some intense lecturing, isn't it? Now, you've learned the rules for the HPT axis. And I am here to tell you that once you know the rules for the HPT axis, you know the rules for the HPA and HPG. Yes, you do. How many of my ladies out there are on birth control pills? Well, let's talk about birth control pills. Yeah, some of you raised your hand. Okay. Guess what? Birth control pills I know this is a very long lecture. Yes, it is. This is why I invited you all to join me live. It's a hard one, but we're almost done with the hard part. For the next 10 slides, 12 slides, whatever, it's easy peasy. It's just me telling you about other hormones. The hard part was the regulation that I just went through for HPX axes. So let's just have a little fun with how do birth control pills work. It's kind of fun. And I have a funny story to go with this. So in the HPG, G stands for gonads, right? Ovaries, testes. Okay. Well, what are the hormones? The hypothalamus releases gonadotropin releasing hormone. So the rules stay, but the names of the hormones change. Obviously, it's a different axis. When the pituitary binds gonadotropin releasing hormone on its receptors, then the anterior pituitary releases two hormones, LH and FSH. In a woman, these two hormones mature a woman's eggs, okay? Egg is not the right term to say, but until we get to the reproductive system, and I teach you your proper words, egg is something that a woman understands and men understand, right? She ovulates an egg. No, we don't ovulate an egg, but anyway. So LH and FSH stimulate her gonads, and they basically make her eggs start to ripen, for a lack of a better term until I get there, and ovulate. And then the gonads release estrogen and progesterone. And estrogen and progesterone feed back, but it's mostly estrogen that feeds back to the hypothalamus. So estrogen feeds back to the hypothalamus, so does progesterone, but it's mostly estrogen's job. And progesterone, its primary job is to go after the uterus And if the woman were to have sex and get pregnant, it prepares the uterus for implantation. Okay, so this is the typical pathway. Now, if you are taking birth control pills, you are taking an exogenous pill of estrogen and progesterone. You are taking that pill. The hormone in that pill, those hormones in that pill, are the same kinds of hormones your ovaries make, ladies. They are the same. So that means all of this estrogen and progesterone are in your body. Yes, your uterus prepares for implantation, gets a little bigger, you retain water. That's why when you're on the pill, you actually gain a little weight from this. But the estrogen feeds back to your hypothalamus, and you taking your daily pill, or if you get the injections, or you've got the implanted estrogen in your arm, what this means is your hypothalamic receptors are constantly populated. And what that tells the hypothalamus is this. It's the ovary's way of saying, hey, hypothalamus, we just ovulated because you told us to start making the eggs grow, and we ovulated. We ovulated like you said for us to do, and probably you should not tell us to keep ovulating because we don't want to have multiple eggs released and have twins or triplets or quadruplets. Having multiple pregnancies at the same time is actually a high risk pregnancy for a woman. So having twins, triplets is not considered to be an ideal outcome. It can have complications. So the estrogen that you're taking in your birth control pill feeds back to your brain and says, hey, we've got a lot of estrogen. So in your body, ladies, your GnRH goes down, your LH and FSH go down. And this means while you're taking the pill, your ovaries are not going to ovulate and release an oocyte. No oocyte, even though you're having sex, means you're not going to get pregnant. So birth control. You are basically convincing your hypothalamus that you are already pregnant. That is what you're doing. Because when you get pregnant with that little parasite in your uterus, the estrogen and progesterone levels stay high. They feed back to your hypothalamus and basically say to your hypothalamus, do not tell us to ovulate us again because we are already pregnant. And I'm here to tell you that in some women, when they get pregnant, this negative feedback inhibition fails. They do ovulate again. They can get pregnant while already pregnant and have, quote, a twin birth, but when they birth the babies, one looks full term and one looks severely premature. That's negative feedback inhibition failure. We do not want that to happen. That's rare that it happens, but it has happened. So ladies, you taking birth control means you're telling your brain you're already pregnant and you shouldn't ovulate again. Now, you can imagine if you're on this birth control pill for a long time, that your hypothalamus goes like this. Oh my gosh, we've been pregnant for so long. I'm just going to take it. You let me know when we're not pregnant anymore. And you stop taking your pill, and the estrogen and progesterone levels start to come down, but your hypothalamus is still going. And some women don't have this process rev back up again quickly. It takes them a while. And it's because this HPG pathway has been shut down for so long. Now, usually I get a female in the class going, oh, so how long should I be on the pill and then stop it? No. Most women don't have that kind of problem. If you stop taking the pill, the system, given enough time, will rev itself back up again. That's why usually doctors say to give it a year before you seek medical help, if this is the case. They want to give it a year for everything to kind of reset and go back to the way it should be. So that's kind of cool that when you're taking a birth control pill, you're telling your brain you're already pregnant, so that you, and when this happens when you are pregnant, it feeds back the same way to your hypothalamus to say, don't let us ovulate again. We're already pregnant. We don't want to be pregnant on top of a pregnancy. And I want to tell you a funny, I think it's a funny story, hilarious. I had to teach this negative feedback inhibition, HPT, HPG pathway to my oldest son, Hayden, when he was in high school. He was in an advanced biology class in high school. And it was very challenging mostly because the high school teacher was teaching high school biology, which is appropriate, but using the UC Irvine Biomajors textbook test bank to make his tests for the kids. So they were totally outmatched. They were being tested like they were biomajors at UC Irvine or UCLA. Not okay. Total mismatch. So Hayden got very frustrated and I started tutoring him, and it helped, but not much. We would study for weeks just for a quiz, and even longer for exams. I mean, we were just studying nonstop. And his grades got a little bit better, but it was very frustrating. And with enough time, his friends that were in the class said, you know, you're doing okay on these quizzes and we're studying like crazy and we're still getting D's and F's. And Hayden said, well, my mom teaches this, so she's tutoring me at home. Next thing I know, the parents are contacting me and saying, can you please tutor our boy? I said, yes. So on the weekends, Friday nights, 6 hours on Saturday, 6 hours on Sunday, I'd be tutoring these boys just to get them to get a C on quizzes. I mean, we were putting in some hard work. And it sounds gross, but we would go upstairs. I have a very big bedroom and I have big mirrored doors, and I would bring home dry erase markers and I would use my mirrored doors as a blackboard, basically, as a whiteboard. So I had like sometimes 17 high school boys in my bedroom, which sounds awful to say, but I was really tutoring them, okay? And so I'm tutoring them, and I just go through the HPG pathway like I did with you. And I said, so when a woman becomes pregnant, the estrogen and progesterone feed back to the hypothalamus, populate the receptors, and that tells the hypothalamus, hey, we're already pregnant. Don't make us ovulate and get us and basically run the risk of getting pregnant on top of a already existing pregnancy. And in this group of boys, 2 of them were twin brothers. And I was talking about twins. So of course they were interested in this. And one of them, he raises his hand. He says, Mrs. Street, why would a woman want this to happen? And I said, oh, baby, Jeffrey, no, she doesn't want this to happen. She doesn't want to have a pregnancy that's been going on for 4 months and then get pregnant with another pregnancy. And now the fetuses are going to be, different ages, and it's very dangerous when one is born, the other one's going to be born. It's not good. And this is not what she wants. And he goes, no. I mean, why? And he was very upset. He goes, why would she want to have sex if she's already pregnant? And I, not thinking, just being very blunt and honest, I replied with, the only thing I knew. I was like, because it's fun and it feels good. Which made my son just go, oh. And so Jeffrey raises his hand again and he goes, no, Mrs. Street, I know sex is fun and feels good. And I'm like, oh. He goes, but why? Won't that hurt the baby? And I went, oh, well, you know, Jeffrey, when the woman's really pregnant and her belly's really big, there are different positions that you can do during that time. You can do, I mean, you don't have to do missionary style. So the man doesn't have to lay down on her, or woman in these days and age. I said, there's doggy style, you can go sideways, you can do the spooning thing. There's lots of different positions. And again, my son's like, oh. Jeffrey raises his hand again. And he says, no, Mrs. Street, I know that there are different positions. That's not what I mean. I'm like, Jeffrey, then what do you mean? He goes, won't the man's penis entering the woman hurt the baby? And all of a sudden I had visions of what he was seeing happening in his head, of the man's penis thrusting in and out of the vagina. And I had visions of him thinking of the baby going, like the eye is being poked or something. And I had to say, oh, Jeffrey, no, let's go back. We learned the anatomy. I'm like, remember, there's the vagina and then the uterus, and then there's this muscle called the cervix, and it's got a hole, tiny little hole, this big, tiny little hole, just big enough for sperm to get through. Not a penis. It's this tiny, super tiny. And Jeffrey's going, oh yeah, okay, now I remember. So I'm like, you can push as hard as you want. You're not getting through that. And at that point, my husband walks by and he goes, how big is that hole again? I'm like, is this big? Is this super tiny? And my husband goes, gentlemen, I can get through that hole. And then my son again was like, oh. So that's my funny estrogen progesterone story with teenage boys. And it all stemmed from how does birth control work? So let me finish quickly now the rest of this PowerPoint. I'm just going to highlight some hormones real quickly. Now that we've learned the negative feedback pathway, now I'm going to switch to a different endocrine gland called the parathyroid gland. Para means next to. These tiny little dots that you're seeing embedded in the thyroid gland are parathyroid glands. They are responsible for maintaining calcium levels in your blood. So the calcium levels in your plasma. If the calcium levels get too low, deviation too low, the parathyroid glands release parathyroid hormone, and this tells cells in your body to increase the calcium levels. So this is negative feedback. Deviation and correction go in opposite direction. And this is a humoral mechanism. What cells in the body respond to parathyroid hormone? What are the target cells? Bone, so osteoclasts will chew up the bone matrix and release more calcium into the blood. Your digestive system will absorb more calcium from your diet, and your kidneys will make sure that they don't release calcium in the urine. So they basically are going to reabsorb any calcium that got filtered so that it doesn't end up in your urine. Those are the three targets. Another set of endocrine glands are found on the top of your kidneys, the adrenal glands. We already learned about the adrenal medulla. That we learned in lecture unit 3 with the autonomic nervous system. And we should remember all of this part. our focus now is on the cortex of the adrenal glands, the outer layer here. And the outer layer has 3 zones going from external to deep, or another way of saying that is superficial to deep. Okay, so the outer layer is the zona glomerulosa, the middle layer is the zona fasciculata, and the most internal layer is superficial or internal. All right, swap those. You get what I'm saying. I'm getting tired. The zona reticularis. The zona glomerulosa releases hormones that are going to regulate water and salt. We call them mineralocorticoids, and the best example of that is aldosterone. The middle layer, the zona fasciculata, releases hormones that are glucocorticoids. They help regulate glucose in your bloodstream. The best example of that is cortisol. And the most internal layer releases a male-like hormone, very similar to testosterone. We call it an androgen, but it's called DHEA, dihydroepiandrosterone, DHEA. Students oftentimes ask, well, what does DHEA do if it's a male steroid kind of hormone? And the answer is, if you're already male, it does very little for you. Your male secondary sex characteristics come from testosterone. But if you're female, DHEA, ladies, gives you wonderful things like axillary hair and pubic hair. So guess what you look like if this layer fails? Then you don't have DHEA, and you don't have to shave or wax in your armpits or your nether regions. Think about that. You would be hairless. And right about now, I get a lot of people going, really? Oh. So that's kind of cool to think about. Again, the adrenal cortex is the outer layer. We're not worried about the adrenal medulla. That was so Unit 3. The outer layer, the adrenal cortex. And this outer layer obeys the HPA pathway. And it has the same rules that we learned about with the HPT, with the negative feedback inhibition. Same rules we learned with the HPG. In this case, the hormones are, they are corticotropin releasing hormone from the hypothalamus. It is ACTH, adrenocorticotropin hormone from the anterior pituitary, and that stimulates the outer layer of the adrenal gland, the cortex, specifically the zona fasciculata. So that's the middle layer of the cortex, and that middle layer releases cortisol. Only the middle layer of the cortex obeys this HPA command. Only the middle layer, cortisol, obeys a hormonal pathway. The other two, aldosterone and DHEA, follow a humoral pathway. Something in the blood triggers them to be released. I do not ask any questions on DHEA. I save questions on DHEA for physiology. So you can delete that layer if you want to. We will learn more of aldosterone, specifically when we learn about the kidneys. So I'm gonna just say to you for right now, what you need to know for aldosterone is that it stimulates your kidneys to reabsorb salt and water. If you reabsorb more salt and water, then your blood pressure goes up because your blood volume is going up. You're reabsorbing salt and water. The pancreas is a mixed gland. It is both exocrine and endocrine. It is actually about 98% exocrine, which means it's releasing digestive enzymes. And you will learn about this exocrine function in more detail in your digestive system lecture. The endocrine portion is only 2% of the pancreatic mass. And the endocrine part, we can actually see histologically. These small little areas that stain differently compared to the outer area that seems to stain much more dark. And those lighter areas are called pancreatic islets. And that's the endocrine portion of the pancreas. The pancreatic islets, an old term for them, are islets of Langerhans. And there are different cells in there. There are beta cells whose job it is to release insulin, and insulin is released in a humoral fashion. When your blood glucose levels go up, insulin is released, and then the cells of your body that are insulin dependent, like skeletal muscle and fat, take the glucose from your blood and use that glucose as fuel. Alpha cells release glucagon. And when your blood glucose levels are too low, glucagon is released, and the liver releases glucose that it has stored so that you can maintain your glucose levels for your brain. Because in between meals, you would hate to just go and lose consciousness because you don't have fuel for your brain. So again, in your pancreatic islets, you have mostly beta cells whose job it is to release insulin. And I just told you what cells it targets. It's primarily skeletal muscle and adipose tissue. Glucagon is going to target primarily the liver and tell it to release glucose. Glucose is stored in the liver as a long chain of glucose called glycogen. So the liver will cut the glycogen up and release little pieces of glucose. You have seen and taken a test already. Here is the pancreas. Here is your celiac trunk with your gastric artery, your splenic artery. Here's the spleen out here, and then the hepatic artery going to the liver, which has been removed. And the stomach has been removed from this picture. This part right here, curving, is called the duodenum. It's the first part of your small intestine. And this portion of the pancreas kind of nestles in the curvature of that duodenum, and that's called the head of the pancreas. The middle part is called the body, and this part way out here is called the tail. So the pancreas has a head, body, and tail. There are other cells in the pancreatic islets that release other hormones. I don't test on them, but you should know that there are other hormones and other cell types that are produced from the pancreatic islets beyond insulin and glucagon, especially when you get to physiology. Of course, this insulin is of particular interest to us clinically because we think of diabetes mellitus. Type 1 diabetes mellitus is usually associated with pancreatic failure. Specifically, the beta cells have been destroyed. In the old days, it used to be called juvenile onset or insulin-dependent diabetes. We no longer call it that. We say type 1 diabetes. Type 2 diabetes used to be called adult onset or insulin independent. We don't call it those anymore. It's type 2. And usually this is a problem related with obesity. And the increased weight In this person, they might have actually adequate levels of insulin. They're not having a problem producing it for most people. It's just a problem with the target cells responding. The excessive weight can make the insulin receptors be removed from the cell membrane. And then the insulin that the person is releasing, they don't respond to. So it's like they're not paying, their body is not paying attention to the insulin. We do know if the person watches their diet, tries to lose some weight, just as little as 10%, we can see some of those receptors come back and the person has better response to the insulin. Arguably, type 2 diabetes is can be prevented and can be cured in many cases with some weight loss and diet management. Arguably, not always, but arguably many times it is. Last couple of slides, few slides. The pineal gland, we already learned about that. The pineal gland is part of the epithalamus. So here's our thalamus, and our pineal gland was that cute little nub that I showed you on the sheep brain. We didn't have a chance to dissect that together, which is unfortunate. Pineal gland releases melatonin primarily. There are other hormones it releases and neurotransmitters, but melatonin is the big one that we want to think of. Melatonin helps your brain process, is it daytime, nighttime? Should I be sleeping? Should I be awake? These sleep cycles change seasonally. When the days get longer or days get shorter, when the sun goes down, you get very tired. The lack of sunlight hitting your retina changes the pineal gland activity and it starts to release a lot of melatonin, and that creates the sleepiness. Some people don't have enough melatonin and they can have mood disorders. And we also know that melatonin can be good as an antioxidant and can have anti-cancer properties. That's a correlation, not a cause and effect, just a correlation. Real quickly, the gonads, I've been talking about them for a while. The males have testes. They are going to respond to FSH and LH from the anterior pituitary, and as a result, the testes are going to have spermatogenesis. So the sperm will produce and mature, and as a result, hormones are released from the testis, primarily testosterone in men with a little bit of estrogen. And we'll talk more about that when we get to the reproductive system. For the females, their gonads are ovaries, and they have these repeating structures called follicles. Sounds a lot like the thyroid gland. This picture on this slide and this picture for the testes can actually be found in your histology packet for Lab Unit 4. The ovaries and testes both are exocrine and endocrine. I kind of talked about that. Something that's exocrine reaches the surface of the body, like your oocytes and sperm. Endocrine means that these are, in the case of the women, releasing estrogen and progesterone, which I talked about before when I was telling you about birth control pills. There are all sorts of cells out here and cells that are here that are part of the ovarian cycle, like theca folliculi cells and granulosa cells. And we'll talk more about those when we get to the reproductive system. Well, that was a whirlwind. How are you doing? I am finished. I'm going to come back to you all, and I'm going to stop. Hold on, let me stop recording. There we go. Yes.